We are live?
Yeah, we are live now.
Okay. A very good morning, good afternoon, and good evening to all friends and colleagues all around the world. Here we are again with our famous foreigner sessions, and today we are going to talk about periodontology. And uh, it's by choice that the host and the speaker both are periodontists today. So this is Dr. and Professor Pratinder Singh, and the speaker is Dr. Meizi Eliezer from Israel.
Yeah.
And I would like to introduce the speaker for today. She's a trusted dental surgeon who has completed her 3 years of post-graduation in an EFP accredited program in periodontology. She is well-driven, ambitious, and very highly motivated, whilst paying attention to every detail in her clinics. An experienced doctor who has served 10 years successfully diagnosing, treating, and managing patients' oral illness and diseases. 7 years of experience working in a research lab in dental animal research and cell culture. That's an amazing CV, 14 publications in respectable journals, won several prizes regarding research, lecturing around the world in aspects of periodontology, oral implantology, soft tissue management. So today we have a very amazing topic. Dr. Meizi is going to talk about, that is gingival recession and the techniques to cover, that is the root coverage techniques. She's going to give us an insight about that. Welcome, Dr. Meizi.
Thank you very much. Thank you so much, Professor Singh. Thank you very much. I'm happy to be here. Thank you for inviting me.
Oh, we are glad as well to have you as a speaker. And Dr. Meizi, I would like to ask you, how is the experience to be in top 100 by the global summits?
This is an amazing feeling. I feel I worked very hard for where I came, and I'm very happy that my colleagues are appreciating my work and actually chose me to be in top 100. This is an amazing compliment, and I hope we will always can learn from each other. This is an amazing platform to learn from one another. So thank you very much for that.
Well, these words from you are really very motivating for us, and we are hoping to get more doctors on our platform. And we have a very dedicated team which is working on it day and night to bring all the doctors on same platform. We are just not talking about dentistry, we are talking about medicine, we are talking about pharmacy, we are talking about optometry, chiropractors, and every doctor in medicine. So our aims and objectives are quite wide, and we are achieving them with great results. Okay, this was about global summits and top 100. Dr. Meizi, how do you feel as a periodontist? What do you think is the role of a periodontist in a dental setup?
Well, we have a lot of hats when we are treating gums and gums disease. So we can treat the disease itself, like periodontitis, chronic periodontitis, and aggressive periodontitis. And of course, today there is another classification. And we can treat also after the patient is healing from the disease, or there is some patient that develop some, let's say like a recession, they develop it. It doesn't necessarily they have a periodontal disease, but they develop in the recession because of all kinds of multiple, it causes. It can be a brushing, hard brushing. It can be also orthodontics. So, and then they develop a recession, which is the area that exposed the roots, and then suddenly the patient feel uncomfortable. It's hurting him. It's sensitive. Aesthetically, it's unpleasant, and this is where we also come and treat those patients. And of course, there is the hat of being to do extraction with GBR, or to do GBR before implantology. So this is another hat of us. So I feel that we have a lot of hat, and overall our knowledge about the gums and about the periodontal tissue around the teeth and around the implants help us to get a very good results at the end of the day for our patients.
Oh, well, that's a real great, uh, aims and what we going to deal with the gums. So, do you believe in that statement that periodontics really forms the basis of any other treatment? Like we need to have a clearance from a periodontist to start any other treatment. Do you believe in the statement, or I'm
I believe,
exaggerating, or I'm
well,
exaggerating on that?
I think that a general practitioner has the knowledge to understand, and of course, he needs to check the patient with a probe, but I hope they're doing it. So you check the patient with the probe, and then, or you see in the x-ray that the patient suffer from a periodontal disease. So this is the time to refer. I don't think that every patient should come and be checked by me, because this is why there is the general practitioner. They know how to diagnose. A general practitioner we learn how to diagnose periodontal disease, and this is a time to refer when we see it. This is time to refer to a periodontist.
Great. And with latest techniques coming up, uh, in the last 5 years, what we've noticed is we have lot many techniques coming for root coverage. Suddenly, root coverage is coming to be a latest treatment option in a dental setup, or you can say dental hospital. So how do you want us to tell that yes, root coverage is a great treatment option for exposed roots?
I think that recession coverage, it's a great technique to cover a root exposure. Of course, we need to know the rules and we need to know the criteria when we can use and we can actually perform the surgery. It's a very sensitive technique. It's you have to know what you're doing. You have to have the right tools, the right sutures, and of course, the experience, the knowledge, and the understanding of the tissue. So I think that not everybody can do it, but they can diagnose to which cases you should refer to a periodontist to do the recession coverage. And it's a great technique to cover the roots and to help the patient to reduce cold sensitivity, to, of course, aesthetically, to increase the aesthetic demands, and of course, to reduce the option to get more recessions in the future.
Great. And since you're associated with EFP, that is the European Federation of Periodontology, I guess you have some nice names with you carrying on these techniques, Anton Skulian, and
Yeah,
so it's always great to hear latest treatments related. Shokran's PRF is adding to our recession procedures, Skulian's techniques, and
yeah.
the audience is going to hear a lot from you today regarding root coverage, and this is going to expand our horizons. The new doctors, the general practitioners, and the new beginners in periodontology. That what in store do we have for various root coverage procedures? So I think the audience must be waiting for a great presentation from you.
Thank
I would
you.
like to thank you again on behalf of
Thank
Global
you.
Summits that you have kindly come online to share your experience and expertise. Over to you, Dr. Meizi.
Thank you very much. Thank you. And I'm very happy to be here. So I will now switch for my presentation. Okay, so everybody see that now, right? You can see it, right, Professor Singh?
Yes, ma'am. Yes, ma'am. You can do it
Okay,
if you want.
great.
Yes, we can see. Perfect. You
Lovely.
can you
So
can do it. You can do it full screen, ma'am.
yeah, this is full screen now. It's
Okay,
okay?
ma'am.
Yeah.
Go ahead. Thank you.
Okay, thank you. So thank you very much for everybody for joining me today. My topic for today is about recession coverage the right way. So my name is Meizi, and I have studied my periodontology specialization in Bern University in Switzerland. I learned from Professor Anton Skulian. He was my mentor. So everything I know is I want to thank him for that. I learned a lot in Bern University, and everything I learned, I applied, and I also have some modification of my own for the procedure. And I'm having a DMD, Doctor Medical Dentistry from Israel, a Master of Science from Tel Aviv University from Israel. And as you say, thing, I am EFP accredited. So today I want to show you what is my right way to do recession coverage and how to do it. So before we start, I want to show you the recession coverage, the Swiss Bern concept. So I want to show you the before and after, how you get from that patient with recessions all over from 21 till 25, how you get to such a nice gums that have no recession at all with 100% coverage. So everything I'm going to talk with you about today, I'm having also other lectures in my Perio Home YouTube channel, which you can see also live surgeries, how I perform the stuff. And also I have a website that's called periohome.com that over there you can see also, I have articles and videos. And of course, I'm writing there the materials that I'm used. So you can also see and be exposed to that and maybe use the same techniques. So I would like to talk with you today about the etiology and classification of recession coverage. I want to share with you today the non-surgical treatment for recessions. Yes, there is some. And the surgical treatment for recession, which is basically the tunnel technique. This is what the Swiss way, the tunnel technique. There is two techniques that called lateral closed tunnel and modified closed advanced tunnel technique, coronally advanced tunnel technique. And I developed a 3-steps protocol for recession coverage in order that when we are going to the surgery, we'll have an easy way to remember how to do it. I want to talk to you about what is the advantages of using enamel matrix derivatives, or what is the advantages to use hyaluronic acid. When I'm using those modified agents, I will share with you later on. And of course, to show you a case and video presentations about some recession coverage. So in our clinics, we see it all the time. All the time, patients come and we check their gums and we see some recessions. We can see patients, they are old with recessions, old patient with recession. We can see young patient with recessions. We can see patients that they are in the middle of orthodontic treatments. And we can see a patient that the mouth is really spectacular, clean, everything is looking great, no plaque at all, and suddenly we can see a recession somewhere. And then we are trying to ask ourselves why those recessions are actually happen. And later on, we will discuss about it as well. The definitions of recession is actually the displacement of marginal tissue apically to the cemento enamel junction. So if we have here the cemento enamel junction, anything that the gums going down from the cemento enamel junction, this is actually a recession. You can have a localized recession, which is in one tooth, or maybe localized by means this is only in the area of the buccal of the tooth. It can be or it can be generalized, many teeth. It can be one next to another, and it can be also one in the upper and one in the lower. It can be in different surfaces, which means or the buccal, it can be in the lingual or palatal, it can be in the mesial or distal, and of course it can also involve several surfaces. And what is the most important from this definition is the loss of clinical attachment. Every recession means loss of clinical attachment because there is no bone holding in this area. If there is no bone and there is a receding gums, that means that there is loss of clinical attachment for that tooth. So for me, recession coverage is bringing back the clinical attachment of the tooth. The prevalence of recessions by Albander and Kingman, they checked a lot of patients, and they have seen that 90% of the people that have recession is between 30 to 90 years old, which this is a big, of course, big gap of age. And there is about 40% of them are between 30 to 40 years old. They said that women has more recession compared to men, which when I read this article, I was a bit suspect of it because there is more women on coming to be checked than men. So maybe they have seen more women than men. And there are more recession in the buccal surfaces. This is also to check buccal recession is easier than to check lingual or palatal recession. So and I can tell you, I see also lingual and palatal recessions, and of course also in the buccal. So, but this is their research, and this is what they said, that there is a recession more in the canine, premolar, and molars. And the recession is not new. Already Woffer described that in 1969, that 8% of the children and 100% of the adults over 50 years are having recession. And this is more pronounced when the tooth is in malposition or maybe there is traumatic brushing. So you can see here malposition of the tooth, and you can see the frenulum that pushing down, and here you can see the recession coming in. Stoner in 1980 said that the first premolar and mandibular teeth are having more recession than others, and also canine. And the reason he said this is because the keratinized gingiva is decreasing in this area. So this is why he said the recession is more developing there. And Cernio in 1994 said that it's more on the buccal surfaces, like you can see here. And Slutsky in 2008 said something very interesting about orthodontic treatment, that 23% of the people that going to have or they're going to do orthodontics has a recession versus 11% the people that has no ortho had only 11% has a recession. And also interesting is the people that had a recession, the recession is 3 millimeter and more. 8% out of them is 3 millimeter and more versus people that has no orthodontic treatment, that did no orthodontic treatment. So their recession was less than 3 millimeter. Only 0.9% was more than 3 millimeter. So why actually this recession occurred? So what's happened when we have an inflammation in the area of, let's say, the buccal area and the gums? We have inflammation, and what's happened to the epithelium? This is like a defense mechanism. It is proliferated. The epithelium proliferate in order to protect the gums. As a result of this proliferation, the retapex, which is this is occur when we have an inflammation, we have increased epithelial proliferation, the retapex coming into the surface, and the retapex is actually the entrance of the connective tissue. So the connective tissue is coming and pushing the epithelium up, and then the epithelium, what's happened is actually closing down to the area of the root. So then like a little window or a gap is occurring. So the recession is actually occurring. So this is an area which of course accumulate more plaque, more bacteria, and then the recession is actually increasing during time. So what are the factors that actually influence the recession? There is the predisposing factor. That means this is the factor that the patient comes with. For example, inadequate attached gingiva. So the gingiva is thinner, or malposition of the teeth, which causing to the buccal plate to be pushed, and then there is more recession. So this is the factors that the patient come with. And the precipitating factors are the factors that the patient actually can, let's say, cause the recession. For example, like a very hard brushing, like if it's a recurrent inflammation, gingivitis that comes and push the gums. As you can see here, you have a plug that pushing the gums, or iatrogenic factor. For example, if we're talking about some piercing, the piercing also can cause to receding gums. So as we can see, the etiology is multifactorial. And I want to talk to you about some of the factors that I see in my clinic. For example, the piercing. The piercing can affect and can cause recession. For example, you can see here a lip, you can see here a piercing, and you can see here the recession, exactly at the same spot. You can see also a piercing in the tongue that actually banging on the tooth, on that tooth, and you can see a recession on the lingual area, and you can see also a recession on the buccal area. You can see also in this patient that the piercing is on the upper left lip, and you can see the recession that caused on the upper left lip compared to the right area that has no recession. And of course, calculus or plaque formation can cause a recession. We can see here a patient, an extreme case of a patient with calculus. You can see he came to our clinic, and you can see the calculus all over his gums and also in the floor of his mouth. And when we when we took out this big calculus that sat in the floor of his mouth, also a tooth came along with it. And after I have done the deep cleaning for him, you can see the recessions that was under the calculus. And it can also cause by a plaque formation. Here is a small plaque formation that pushes the gums, and also this can also cause to a recession. And by the way, this article is sitting here in my periohome.com. This is an article that I talked about this patient and what kind of treatment we performed. So the root recession classification. So the classification for root recession is very important for diagnosis, for prognosis, for treatment planning, and for communication between clinicians. Now, during the years, there was various of classification for recessions, and you can see all of them here on my presentation. Now, there are two important classifications: the Miller classification, 1985, and the Cario classification, 2011. I'm going to talk about Miller classification. So the Miller classification talks about two things. It talks about the extent of the gingival recession defects. It means how long its extent, to where its extent, if it's extent until the mucogingival junction or under the mucogingival junction. And it's also talking about the interdental area. Do we have a loss of the interdental papilla or bone, or we don't have a loss of interdental bone? And this classification is predicting if we are going to be successful in our recession coverage or no. So I want to talk to you about the first classification. Miller class 1 talk about, very simple, they talk about that the extent of the recession is not until the mucogingival junction. It's actually above the mucogingival junction. And they said there is no periodontal loss, no bone and no tissue in the interproximal area. And for that, if we are going for Miller class 1, there is 100% root coverage. We can expect 100% root coverage. If we're talking about Miller class 2, the extent of the recession is up to the mucogingival junction or beyond the mucogingival junction, and still there is no bone or tissue loss in the interproximal area. So we can expect also here 100% root coverage. Now for Miller class 3, what is the difference is the interproximal area, we do have a bone or soft tissue loss. And for that, we saying that we shouldn't say our patient we will get 100% root coverage, which we will actually have partial root coverage. But sometimes there is a surprise also, we get some 100% root coverage, but we should not expect it. And if we're talking about Miller class 4, in that case, we have here, of course, severe periodontal loss, bone and soft tissue. And for that, we should say there is no root coverage possible procedure, not root coverage procedure possible in this kind of Miller class 4. It's not possible to make a root coverage. So what are the indications for treatment? So first of all, I would like to do a recession coverage procedure in order to help my patients to clean better. Because the patient that has a recession like that, he has sensitivity. And once a patient has sensitivity to clean an area, a plaque and accumulation will always be here, what will cause to more recession to occur. So this is for prevention of gingivitis and also for root caries and to help our patient to facilitate oral health, and also to help a patient to get an aesthetic result. If a patient is having a supragingival smile and her canine here are exposing a recession, she's having a hard time to smile properly, and she's always cover her smile with her hand, and she feel uncomfortable. Of course, she feels sensitivity to cold because when she's brushing and when she drinks cold water, the area of the roots is exposed and sensitivity is occurred. And I would like to do a procedure of recession coverage in order also to increase the attached gingiva. Because once the attached gingiva will be here and I'm increasing it, the patient will have less accumulated plaque, and it will be able to clean better. So what are the treatments that are available for us for recession coverage? We have non-surgical treatment and surgical treatment. So the non-surgical treatment, I can tell you there is a few things to do. First of all, you can see, take off the piercing. Take off the piercing in order not to increase the recession. Uh, Perform root planning and scaling in order to get to lose this calculus and plaque accumulation in order to bring back the gums to the right level. And of course, use the right tools, use the right toothbrush. As you can see here, this is a special care toothbrush of Tepe, very, very sensitive. This is in the area where the patients say, I cannot brush any longer. And of course, he needs to brush in the area of recessions until you treated him. So you can use this kind of brush. And if you're using an electric brush, we should guide them how to brush correctly next to the gum. And the electric toothbrush today has also detective of a pressure. So if the patient is putting too much pressure, the electric toothbrush tells him to stop this kind of pressure, which prevents the patient from having more recession. Now, this is also like I want to show you an example of non-surgical treatment. A patient came to me sent by another doctor, and he said, okay, she has a recession. When I look on that patient, she's 14 years old at the time, and during orthodontic treatment, her orthodontist wanted to take off the brace because of this kind of inflammation. And I looked carefully and I said, no, this is not a recession. This is actually the crown. The crown of her teeth looks like that. This is the crown. So what I had to do is diagnose correctly, and I've treated her with a diode laser and curettage. And you can see after 2 weeks, you can see here the gums that she got. This is a healthy gums with a touch gingiva, and this just to correct the diagnosis. That was not a recession. Again, what is the best treatment of this patient? She sent to me by another doctor, which was also misdiagnosed because she thought she has a recession here because of the other tooth has a smaller clinical crown. And when I look carefully, I said, this is the clinical crown. Here is the CJ. And those teeth, actually, when they finish her orthodontic treatment, the roots of those teeth were more lingually, and the gums were covering the root. So what I actually said here that the best treatment is the correct diagnosis, because if I would have performed here a recession coverage, that would not been successful. She wouldn't get any results. And again, a non-surgical treatment. Frenectomy for me is not a surgery. Okay, I cut the frenulum with a laser, of course, but this is not a surgery, which I'm opening flap or something like that. So you can see here a recession and a frenulum attached to the area of the recession, and of course pushing it down. So by just taking this frenulum and putting it more apically, you could see the recession is shrinking. Okay, that means the recession, no need of recession coverage in this area. So I want to show you the surgical procedure of the recession coverage. I hope we can see it here. Yeah, you can see this is a Miller class 3 recession, by the way. There is a loss in the interproximal area. Here I'm performing a tunnel technique. This is a laterally closed tunnel. I'm measuring here the area that I need to take the recession. I'm taking subepithelial connective tissue graft, that means under the epithelium to take the connective tissue. I placed here a collagen for the coagulum, and I sutured it. I placed an Emdogen here. And in the special technique of tunnel technique, I am entering the connective tissue graft, the subepithelial connective tissue graft, using a nylon suture, 60, 12 millimeter needle. And you can see the area. Okay, all of this you can also see on my YouTube channel for like a 1-hour video about how I'm performing it from A till Z. See that it's, no, we already did it. Okay, so what are the surgical methods for a tunnel technique? So we have to know there are two sides. We have the recipient sides and we have the donor sides. So the donor side is, for me, is the palate, and I'm using the hard palate. I'm taking the subepithelial connective tissue graft from the hard palate, and the recipient side will get what I got from the donor side. There is another way to take from the donor side is by taking free gingival graft and not subepithelial connective tissue graft. What is the difference? Free gingival graft is taking like a piece of the connective tissue together with the epithelium, versus the subepithelial connective tissue graft is making a cut and taking the connective tissue that lies under the epithelium, and then I'm closing the epithelium. So you can see when I take subepithelial connective tissue graft, you can see after 8 days, you can see the healing. So there is no, the patient doesn't feel any pain. I never had complaints from my patient about this procedure or from the palate, and it closed very, very, very fast. What is the advantages of subepithelial connective tissue graft? This was already introduced by Langer in 85. When we take the subepithelial connective tissue graft from the palate, we have high predictability. We have a blood supply, not just from the graft itself that comes with some of the blood supplies, but also we have a blood supplies from the recipient side. So we have a dual blood supplies from the connective tissue graft and from the recipient side. We have less discomfort or pain in the donor side. About the aesthetic, the tissue that I take from the palate and I implanted it in the recipient side, the epithel that I will get will be the same as the epithel of the recipient side. And we can use it for multiple sites. And because I'm closing this area, there is less chance of contamination. About the disadvantage, this is a very technically demanding, very sensitive, very technically. And the issue is that because we don't see very well, because you have to cut a very narrow very narrow area. You can't see the blood vessels, of course, and you cannot see also the nerves are sitting down. So if you don't know how to do it, you can cut the nerve and can't cut the veins, which can cause, of course, a massive bleeding, and a massive discomfort. You can see here, this is also like after 5 days, you can see how it looks. You can see the suture marks that it left over it, but it will heal completely. You can see here after 3 months of the area how it heals completely. You don't see any remarks of the donor site. So I have an article that I've been part of, a very large group that did this article. This is a systematic review and meta-analysis about using PRF for treatment of gingival recession. Now, what I love in this research, that it's not only about the PRF using a recession coverage. This systematic review and meta-analysis took all of the options by means clinically advanced flap versus using only PRF. If you're using connective tissue graft versus PRF, that means you use recession coverage together with connective tissue graft, and you compare it to using recession coverage with PRF, or using connective tissue graft with Amdogan versus clinically advanced flap with Amdogan versus clinically advanced flap with PRF, and et cetera. And what we have seen, that when we use recession coverage with a connective tissue graft, which this is actually the meta-analysis showed here, we get the best result, the favorite result with connective tissue graft. So connective tissue grafts should be the gold standards for recession coverage in my eyes, and of course with my experience. Why can actually connective tissue graft there is some failure with that, and it can be failed if we using it not correctly, if we are cutting more vessels than necessary, if we are doing flap penetration by means that we cut also of course in the tunnel technique, if we cut also the area that's supposed to be the gums. If we cut it too much, then it can fail because there is too much exposure of the connective tissue graft. If there is a trauma, for example, here a patient that my colleague had an experience 2 days or 3 days after the recession coverage, she had a trauma which caused to a bleeding in the area of the recession coverage. If we use the wrong procedure, for example, here is a free gingival graft that lied over in order to cover the recession. And of course, it was not correct to do it like that. And if there is a piercing left over, for example, this a patient, actually is patient of mine in the beginning when I started to do recession coverage, I didn't push the patient to take out the piercing. I told them, can you please take out the piercing? And she said, yeah, I will take it out. And after this procedure, she came 1 week after, and I could see all this mess. And of course, the tissue lies down this area. And so those things can cause to a failure for the connective tissue graft to actually implant in the area of the recession. So what is the tunnel root coverage techniques. As I said, there are two techniques. There are modified coronally advanced tunnel and there is laterally closed tunnel. And of course, there are the combination of those two. And if we are looking deeply, what is the technique? If we're talking about modified coronary advanced tunnel, we could see that that means to bring coronally, to bring up the to cover up the area. So in order to cover the recession, so we bring it coronally. And what is laterally closed tunnel? And that when we bring from side to side the gums in order to close the recession. So this is laterally closed tunnel. And there are three main steps for recession coverage procedure. This is something that I developed for my students. So I divided it to 3 steps: before surgery, during surgery, and after surgery. And inside the before, during, and after, there is another 3 steps. So before surgery, there are 3 steps to take. Of course, medical history to assess the recession, if it's a recession that I can actually correct, and of course, to say it to the patient, the criteria for success, what the patient needs to do in order for this procedure to be successful. And during the surgery, there are 3 steps to prepare the recipient side. That's first of all, so I'm preparing where is the recession is. I'm preparing the gap between the root and the gums in order that I could implant the connective tissue there. And I'm harvesting the subepithelial connective tissue graft from the palate. And I usually placed a collagen sponge instead of the tissue in order to absorb the bleeding, and I'm suturing it. And to add a modified agent like enamel matrix derivatives or hyaluronic acid, and I'm suturing the flap. And after surgery, the 3 main steps are, of course, immediate instruction after recession surgery. For example, for the next 24 hours, you shouldn't brush, you shouldn't spit, you shouldn't touch the area, don't play it with your tongue, be careful not to play basketball, not to do sport for this time, and try to be as much home as possible because this is a very delicate time. And then there is the early instruction, the 3 weeks after recession coverage, and there is the late instruction. That means up to 6 months after recession coverage, what for example, what the hygienic can do. Can she clean or not? After 6 months, the hygienic can do anything to the area. She can probe, she can clean, she can do deep cleaning. Of course, there is not necessary because if it's a good recession coverage, we will have an attach there. So there is no necessary for that. But up to 6 months, the hygienic should not probe and should not get inside with the curette inside the area. So this is before surgery, medical history, assessed recession, and criteria for success. I would also want to see the tissue, how it looks. Do I need to perform cleaning before I'm going for recession coverage? And I would like to see the recipient root. What if the root is problematic? And I can see there is different layers on the roots. You can see here because probably there was doing some curettage there up to this level, and then I need to add I know that I will need to add a modified agent. This is how my table looks like if I go for surgery. You can see my sutures. I have all of them are nylon sutures, and all of them are different. This is 5-0, 16 millimeter, 5-0, 12 millimeter, 6-0, 16 millimeter, 6-0, 12 millimeter needle. And this is the tunnel instruments. And you can see here that in that case, I placed here a modified agent, the enamel matrix derivatives, but sometimes I'm placing also hyaluronic acid. So this is the 3 steps. So I prepare the recipient side, as you can see here. You can see there is a gap between the root and the gums. And you can see I can come with the laterally closed tunnel in that case. And I'm harvesting from the palate the connective tissue graft. I have to make sure not to hurt the artery and not to take as less as possible, and not to take the fatty tissue, of course, and not to hurt the also there is nerves here. So you can see I'm measuring how much I would like to take, and I'm after that closing the area. Modify agent like enamel matrix derivatives, I'm adding before I'm actually placing the connective tissue graft, and also after I'm placing the connective tissue graft. This is here you can see hyaluronic acid that I'm placing in that area. So I'm placing it also after, not just on the root, but also on the area of the graft, because this is a modified agent that helps to increase the healing process. It makes it, the healing process is faster and better. And you can see here the sutures. This is modified coronally unvest. What you see before, it was laterally closed tunnel. And here you can see modified coronally unvest. Here I prepare the tunnel. You can see that the tissue I harvest from the palate. I'm placing here hyaluronic acid. And you can see here the tissue that comes a bit above. I'm suturing it in a very specific suturing technique. And you can see here the healing after 3 weeks. So what kind of modified agents I have? I'm using cross-link high molecular weight hyaluronic acid, or I'm using enamel matrix derivatives. Now, why I'm using a cross-link hyaluronic acid, the high molecular weight? We did a research about hyaluronic acid and its adjunctive to non-surgical and surgical therapy. This is a systematic review and meta-analysis we conducted in Bern. And I have seen in that, after taking all the articles about hyaluronic acid adding to a non-surgical and surgical periodontal therapy, we have seen that the adjunctive use of hyaluronic acid may improve the clinical outcomes when used in conjunction with non-surgical and surgical therapy. And this is the article the first article we did about hyaluronic acid. The second article we did about hyaluronic acid is about the treatment of to treat single mandibular recession with modified coronally advanced tunnel or laterally closed tunnel, and we add to these procedures hyaluronic acid. Together with sub-epithelial connective tissue graft. And here we could see that when we add the hyaluronic acid to the recession coverage, we get a very nice results. Cross-link hyaluronic acid lead to a predictable root coverage. Another research that we have done is actually to examine 2 hyaluronan preparation on primary human oral fibroblasts. So when we take in the palatal fibroblasts, we would like to know what is how they react when we add them a cross-link hyaluronic acid. And we have seen that it's enhanced the expression of gene encoding type 3 collagen and transforming growth factor beta 3, that both of them are characteristic for scarless wound healing. So we're actually reducing the option to get a scar in our procedure. And also we have seen that to add cross-link hyaluronic acid is enhance the proliferative and migratory and wound healing properties of cell types involving in soft tissue wound healing following regenerative periodontal surgery. So it's when we add the cross-link hyaluronic acid, it enhances and proliferative, migratory wound healing properties. So all kind of cell types that helps to facilitate wound healing. So this is the reason why sometimes I use cross-link hyaluronic acid. It's actually used a lot in dental field, but here I want to concentrate on the recession coverage. So here is some cases that I presented in Aeroperio in Amsterdam 2018. This is also using recession coverage with connective tissue graft, as you can see here, with hyaluronic acid. You can see the hyaluronic acid forming like a mesh on the blood. And you can see here the suturing in lateral closed tunnel. And here is like a 6 months after. So if you would like to see this kind of presentation, this is also on my periohome.com. So again, tunnel technique, the connective tissue graft, hyaluronic acid, you can see the mesh suturing here under. This is the connective tissue graft, and you can see here the suturing of the laterally closed tunnel. So, and when I use Emdogen, enamel matrix derivative, I'm using it in 3 options. First of all, Miller class 3, because we have a loss of a bone, I'm more feeling comfortable to use these enamel matrix derivatives. When I have irregular root surface, I also use enamel matrix derivatives. And when there is a filling that I need to remove, as you can see, there is a filling here that tried to cover the recession. Of course, it couldn't. So I remove the filling and I'm adding enamel matrix derivative in that cases. There is lots of facts about enamel matrix derivatives. I'm using it. I want to not to concentrate on the enamel matrix derivative, but on just why I'm using it. I'm using it because this is a key factor. Sculian 2007 has shown that it's a key factor for cementum and PDL growth. So I want to help to the cementum and to the PDL to growth in that area. Now, wound healing in periodontics has 4 options to heal. Okay, there is option number 1, which we call if we are opening a flap and the flap is closing, or even with a deep cleaning, we can hurt the junctional epithelium. So the healing will be along junctional epithelium or reattachment. Okay, so that the connective tissue will reattach and the long junctional epithelium will be connected to the cementum. This is one way of healing in periodontics. The second way of healing is actually ankylosis or root resorption. When it's happened, it can happen after a trauma or after orthodontics, that the root and the connective tissue graft is actually no more, there is no more barrier. There is a root resorption, or there is an ankylosis, which the bone connect to the root and there is no PDL to actually separate between them, or a connective tissue graft or an epithelium. So this is, of course, a wound healing which we don't like and we don't desire, but it's happened. And there is the wound healing that we are all desire and want. It can be a new attachment. That means we get a new PDL and a new cementum. Or it can be a real regeneration, which is PDL, cementum, and bone. So the difference between new attachment and regeneration is that the bone is also preforming here. And this is something we would like that to happen. So every recession coverage actually will have a new attachment. We'll have a PDL and cementum new to attach to the surface of the root. And if we add bone, that we cannot know. Only CT scan and only re-exposure of the area can show us if we get a new bone or not. So here I have some example of Emdogen, how it's actually causing to regeneration of the area where there is no bone. So you can see here a gap between the root and the bone, a gap here between the root and the bone. And if we go in after 2 years after I'd done my Emdogen treatment, you can see here a bone forming here and a bone forming here. For example, in the lower area, you can see also here an infrabony defect in this area, an infrabony defect in the area of 36 and also 40 and 37. And after a while, you can see after 2 years, you can see the bone reforming here and also in the area of the 36 and 47 and 37. So the indication of using Emdogen, and sometimes I'm also mixing it with bone, is of course to get more bone and to get more healing in the infrabony defect. So I would like to show you some cases. I don't know how much time I already talked. If I have okay, I need to bit more. So here is like an example of a recession of Miller class 3. You can see here the loss of tissue and bone. And you can see here 3 years of follow-up. Yes, it's not 100%. We have still a recession of 2 millimeter, but this was a 12 millimeter recession because it was coming until the tip apically. And here we can see attached gingiva. So now the patient can clean and can be actually can keep these tooth without any recession continues. I don't want to again to show a video because it will take a while, but you can see here recessions, and you can see here after 3 months after the recession, you can see the thickness of the tissue, which helps the patient to clean better. And again, I don't want to show the, okay, here is a patient, 59 years old. She complains about the tooth number 13. She doesn't like the aesthetics. She has a sensitivity when she brushing and when she drinks some cold beverages. This is a Miller class 2 with the papilla class 1 because the papilla come almost until up to the contact point. And you can see after 2 years how the connective tissue is formed. And you can see the recession is actually not longer here. This is 100% coverage. You can see a patient, she's 48 years old. She has she had a pain and the brushing of the area of from canine to canine. And this is a Miller class 1 and papilla class 1 because it almost come until the apex. And you can see the recession coverage with coronally advanced flap. And you can see after that, of course, the tissue is more thickening and the recession is covered. And this is the same patient as 13. She had a recession on the 13. Now she has a recession also on the 22, 23, 24. And she is complained about the aesthetic, of course, and about the brushing, sensitivity to brushing and cold. And this is Miller class 3. Because you can see also the loss of the tissue on the sides. And here you could see the recession, after recession coverage, 2 years after, you can see the gums that she got while she's smiling. Before that, she had like you could see the recession while she was smiling. And also the cover on the 24 and on the 22. There's a result from this covering. Now, I couldn't cover more than that because here, as you can see, there was a filling. And this filling is of course, prosthetic, and this is an artificial material. So the connective tissue gum cannot attach to the artificial material. So I took as much as I can from this artificial material, but I couldn't take too much of it because otherwise it would be a big hole there. So the connective tissue graft can hold only until where is the real tooth is, where is the real cementum is, or until up to the cemento enamel junction. So here you can see her smiling. You can see the long canines. And then you can see after, you can see she got a full coverage. And when she smiled, you can see her gums after 2 years following up. So this is a patient, 30 years old, 10 years after recession, after a orthodontic treatment. You can see here she has like a retainer behind in the palate, in the lingual area, and you can see that she had a loss is about 6 millimeter of recession. Here is about 4 millimeter of recession in the area of 41, 31. And you can see here after 3 months, after recession coverage, and you can see here after 1 year. So you can see the attached gingiva that she got. This is a very good result, which 100% root coverage recession. Now she can brush and she has no issue of cold sensitivity, and she was very happy. Another patient, 48 years old. This is 16 years after unsuccessful orthodontic treatment. She has a sensitivity for brushing, and a lot of plaque and calculus are accumulate in those area. And she's not happy about the aesthetics, because when she smiles, she has a high lip line, and you could see the teeth that looks like rabbit teeth because of these long recessions. So you can see here after 6 months, after recession coverage, you can see the healing and the gums, how the recession is performed. And then now she has no recession. When she smiles, she's very, very happy aesthetically. That was Miller class 3, by the way. So here you can see a patient which is actually Miller class 3, almost class 4, because this is a very, very tricky case, the malposition of the teeth, but we, we had to try. I said to her, okay, I will try. I cannot promise you, but I will try. I'll do my best, because I could see here if she lost those teeth, there is nothing. She could not place anything here, not implants, nothing, because there is almost no bone. So after, this is a Miller class 3, and of course, loss of papilla on the area between 41 to 31. She has also recession on 32 and 42. And you can see after 5 months, she has a covering of the gums in the area of 31, 41. She has a very hard time to clean. I'm not doing Photoshops. I'm taking as that the patient, this is our patient. We cannot present something else, can we? We have to present the truth. So yes, she has a problem of cleaning. She doesn't clean so well, and every 2 months she's coming, and I'm cleaning for her this area, or my hygienist. We try to of course, we're cleaning supragingivally. We don't go deep, just supragingivally, and we explain her over and over again how to clean. Nevertheless, she get a nice result of covering this kind of very hard Miller class 3. Even I would say in some way it could get to Miller class 4, because she has also recession on the lingual side. And this is a patient, 40 years old, before orthodontic treatment. He has a recession. He wanted to do orthodontic treatment to close the gap. The doctor told him that no, he cannot do orthodontic because of this recession. He's afraid. And this patient came to me, and I said, okay, let's perform recession coverage before the orthodontic treatments. This is a Miller class 3. There is also a loss of the interproximal bone. And you can see after 6 months, you can see the recession coverage procedures results. You could see 100% covering. And now he started to go for an orthodontic treatment. Another patient, 19 years old. This is also, he complained about sensitivity for brushing, and of course, aesthetically didn't like it. And this is after 1 year already. The results show 100% coverage and a very nice tissue healing in this area. This was a Miller class 2. And this is a patient, 60 years old, has a high lip line, and he said, I don't like this. I don't know what to do. And some doctors say, okay, maybe we put some filling here. And filling, this is not the solution, because if you put a filling in this kind of recession, the area of the recession will go even more higher. So this is after the procedure. You can see this is about 3 months after the procedure. You can see the root coverage that he got. And of course, he was very happy and he could smile nicely. Another patient with high lip line, didn't like the recession that he has on 13 and 23. You can see here the high lip line and the recession that he has. And this is after the recession. You can see after recession coverage, the results. You can see here that now he has gums when he's smiling. He's actually a model. So this was a Miller class 2, and this is after 1 month. And today is already half a year, 5 months after the procedure. You see a beautiful gums in the area of 13 and 23. I need to put a picture there. So my home taking message for you is, first of all, in order to diagnose correctly your patient, you need time. So when you are examining your patient, please make sure you make time, not just to see if there is a caries or not, but also overrule the gums. If you can see, if you see a recessions, if you are detected early enough, we can treat it and get 100% results. So if you are examined, please don't forget to examine the gums and detect the recessions early in the early age, and not waiting for that to be 10 millimeter recession, because then it's a harder then it's harder to make it 100% results. And very important to also to, of course, to tell your patient how to clean their teeth, and uh, and refer your patient to the right person, the one that shows you pictures before and after, and actually he has the ability to give a good results to your patient. And if somebody is trying to do it by himself, just to you to know, if you don't have the knowledge and if you don't have the skills, even if you don't have the right tools, the gums will not be it will get revenge on you, because the gums are very sensitive, and once we hurting them, sometimes they cannot go back. It will even get worse. I have some pictures from some colleagues of mine that send it to me and now needs help. And I think that if you don't know how to do it and you didn't never did it before, that's the time to send it to another doctor. And if you refer to another doctor, once this doctor help your patient will be thanked to you all his life, because you helped him to get the right procedure, and he will be very happy from the results. So if you have any question, then please, this is the time to ask a question. And this is my email if you want to ask question. So this is my email. You can write me an email to I'm answering my email all the time to a question of my colleagues. Thank you very much. And I want to thank my assistant. And this is here you can see her. And I have a TV that films all my procedures. Thank you very much.